Good afternoon and good evening, everyone. Let's just see who's online. Thank you very much for your continued interest, and for those of you who got good memories, this is a 1 week earlier restart of the teaching series. And the reason I wanted to restart it is because it's good to get the momentum going again. So this will be, as usual, a weekly teaching series. Every second week will be Haempath, and every other week will be an external speaker. We've already got a panel of external speakers set up to the end of May next year, and probably within a few weeks I'll get it sorted to the end of the next of this present academic year, which has just started. Just starting in September. So we've got people right the way through from September through to May and then through to July next year. So today, just to really restart the momentum, I'm going to go back through some heme cases. My colleagues have put together quite a large set of heme cases, which I will go through. Feel free to put your hand up, to nudge Ava to let you speak and ask questions. I'm very happy to be interrupted along the way. I see there's 2 iterations of me. I don't know why that is. So there's two of me. I think someone, Ava, seems to be, is there someone?
I see that too. I'll see what I can do.
Yeah, because there seem to be 3 panelists. There's me and me. One of them has their screen shut off. I don't know who that is. Anyway, we'll carry on. So I'm just wondering because that flashed up, the top one flashed up with someone else's picture on it. I hope someone's not
I think I
impersonating
fixed
me.
it.
Okay, we fixed it. Okay, that's great. Okay, well, so whichever territory you're in, as usual, we'll put out the weekly reminders, but it will be the same time in your territory. We do change our clocks between winter and summer in the UK, but it will be the same time in your territory each Wednesday. So whatever time this is, each Wednesday, and the lectures are recorded and put on the Diagnexia website. There is a bit of a delay in that, but anyone who joins through the webinar can have the recording emailed to them afterwards. That's correct, isn't it, Ava?
Yes.
Yeah, thanks very much. So it's worthwhile. And please feel free to share the information professionally with any of your colleagues. It's completely free to attend, and we don't want, you don't have to ask us permission to share it professionally with your colleagues. You can do that. But if you do that, anyone else who joins, just let us know so we can make sure they're on the list as well. Okay, so without further ado, and those of you who have been here before will know that it can be a bit difficult for me to manage 3 screens at the same time. So you have to bear with me a little bit because I have my clinical information screen and I have the camera screen, and I'm flicking between the 2 constantly. So let's see how we get on. So the first case, I've got some cases from 2 of my colleagues, and I'm sure we won't get through them all today. So we will continue to use these. The next time I talk on Haempath, which will be in a few weeks, I must say next week I'm actually at a coroner's inquest at the same time as the teaching. So, but it will be a very good educational recording that I did recently on myeloma with a lot of case presentation. So it's worthwhile viewing that, and I will be available, I expect, at the end for some questions and answers. There's a little discus. It's very difficult. Let me just get the logistics of this screen set up so I can see. Not that I want to see myself, but it just means everything works a little better. Okay, right. So the first case is Okay, so the first case is a 37-year-old man who was referred with a left mandibular node, thrombocytopenia, neutropenia, and abnormal mononuclear cells in his blood. So he's got low platelets, low white cells, and circulating abnormal cells in his blood. And he's 37. So I'll be, if we could do a kind of like question and answer session, that also relieves the sound of my own voice constantly. So those of you who've heard me talk before, let's try and get this in focus. So this is his marrow. So a bit of cartilage at one end.
I don't think
I've,
the
oh,
screen.
sorry, I'm sorry. You're right. Thank you, Ava.
Of course.
Should see it now. That's better, isn't it? Okay, so this is his marrow. As you can see, it's a really nice long core, certainly adequate. Again, those of you who've been here before, I kind of count the marrow spaces, but I do it very approximately. So I'd probably say 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. I don't know how many cores my colleagues thought. They thought plus and minus 15. So I've been actually a bit conservative about counting the cores, but it probably doesn't matter whether they are 10 or 15. The point is that it's adequate. For someone who's 37, this would be hypercellular. I think it would be hypercellular in almost any context outside the pediatric population. We have still got fat spaces, but if you take the cellularity as being the amount of fat spaces should be approximately equal to the person's age. So if they're 37, should be about 40% fat, 60% hematopoiesis. This is way over 60% hematopoiesis, probably more like 80%, maybe even 90%. And the other thing is that we have lost the paratrabecular fat spaces in many, many places. In fact, there's only a few places where they persist. So there's some paratrabecular fat spaces persisting here. But in this area here, they've been lost. This is just an artifactual hole. Again, they've been lost down there. They've been lost there, lost here. So whatever is in this marrow is abnormal. And then you come down to higher power. And this is interesting. I think you can make a suggestion of a diagnosis based maybe on this field, certainly at slightly higher power. Higher power. Let me just color balance it nicely for you. So has anyone got any suggestions of what this might be? Broad kind of suggestions. You haven't seen the whole thing, of course, so I'll just go through it a bit more. So feel free to put your hands up and suggest anything. So relatively young person in our country, 37, and low platelets, low white cells, circulating abnormal mononuclear cells, and this appearance in the marrow. One higher power. Any suggestions from anyone? Don't be shy. I'm trying to see how we get on. I'm really be really grateful if anyone sticks their neck out. It doesn't matter whether you're right or wrong. If anything, it really tests the facility of being able to contribute through the webinar platform, which I think is important. So is there anyone who'd be prepared to say anything at all? You can even say, I don't know. That would still be sufficient. And then I will go into it.
I've opened up the chat for anyone who wants to make
Okay, that's great. So let me see if I can find the chat. Is that in the Q&A or is it in the chat?
It should be in the chat.
So let me find the chat. I don't want the Q&A. I want the... So, okay. Anyone want to put in the chat what they think? I'll just type something in to get the ball rolling then. So, there's an infiltrate throughout the marrow of these cells here, which are kind of small to medium, and they're all pretty much the same size and morphology. They're also associated with some apoptosis, like there, and there, and there. So we have got some fat spaces, but we've also got these apoptotic bodies here, space there, and there, and there, and there, and there, and there, and there. So given the fact that we've got a relatively diffuse infiltrate involving most of the marrow of these small to medium-sized blasts, which are uniform, they all look the same. They've got relatively stippled chromatin, indistinct though prominent, sorry, distinct though not prominent nucleoli, very scanty cytoplasm, and they're present all the way through the marrow, and they look the same, kind of small to medium, very regular. So the other things that could cause a kind of infiltrate like this, a fairly diffuse infiltrate, could be an acute leukemia, could be either an acute myeloid leukemia or acute lymphoblastic leukemia. An acute myeloid leukemia would tend to have a greater degree of variation in the cell size and shape. A lymphoblastic leukemia might have more prominent nucleoli. And then the other thing it could possibly be is a diffuse large B-cell lymphoma. But again, the cells would tend to be larger and less uniform. And there's one type of high-grade infiltrate, which I've specifically not mentioned, to see if anyone can twig as to what it might be in this case. I'll give you a few seconds and then I'll go to the immunos. No one prepared to mention what high-grade lymphoma I've missed out? I've discounted the acute myeloid leukemia and acute lymphoblastic leukemia. I've discounted diffuse large B-cell lymphoma. There's one type of high-grade lymphoma, Burkitt. Excellent. Thank you, Vinoff. Just seen that. Great. So what are the features that make this Burkitt? So the features are the uniformity of the cells is very common in Burkitt's. You have got this kind of like starry sky pattern, even in the marrow at lower power with these holes. I mean, it is a little bit more difficult to appreciate in the marrow because you've also got fat spaces, but you can see apoptotic bodies in the marrow. It's spread all the way through. I think it can be difficult to distinguish one of these from a lymphoblastic leukemia or a lymphoblastic lymphoma, and without immunos or fish, it's probably technically impossible to distinguish them. But I think the greater uniformity and the kind of like medium size of the cells and not the prominent nucleoli. So lymphoblastic leukemia tends to have a bit more cleared chromatin and more prominent nucleoli. So let's look at the immunos. So these are positive for, I'll go through all the immunos quickly so we can go on to the next case. So strongly positive for CD20, and they were positive for CD79A as well. They were, this is TDT. So I've looked at all the H&Es to these cases, but I haven't actually looked at the immunos yet. So the TDT, importantly, is negative because TDT would be positive in lymphoblastic. The positive for BCL6. So strong nuclear positive to BCL6. negative for BCL2, apart from occasional cells. Key 67 is probably the most important, and that's pretty much 100%. So if there were two immunos you were going to use to distinguish between these, it would be Key 67 and TDT. Because if you know that it's B and it's got Key 67 this high, which is virtually 100%, it's pretty much got to be Burkitt. It can't really be anything else. If it's less than 100%, you might be thinking of a diffuse large B, and then you might want to be considering BCL2 and BCL6 and CD10 to make the distinction between Burkitt and diffuse large B. But in most good going cases, it will be 100%. And if it's 100%, obviously in the UK, we would also do those other immunos I've just mentioned. But I think that you could relatively safely say 100% Key 67 uniform cells, negative for TDT, so not lymphoblastic, so probably Burkitt's. Of course, it may be that in your territory, the treatment differences between Burkitt and lymphoblastic are not different anyway, though they are generally different. Burkitt's is positive for BCL6 and CD10. It's negative in general for BCL2. This is, in fact, the CD10. If I can find it. Yep, there's the CD10. So this is a good going case of Burkitt's. And the EBV was focally positive. Now, I know that in sub-Saharan Africa, a lot of cases of Burkitt's will be EBV positive. That's not always the case in the UK. Not all cases are positive. There is weak positivity in this area, but you would probably see more. But I guess you wouldn't be doing EBV positivity immunohistochemistry. We also did immuno for MYC, which should be positive. Yes, weak, but positive. And MYC immunohistochemistry is rather difficult to interpret, though MYC immunohistochemistry is a good surrogate of the presence of the isolated MYC translocation in Burkitt's. So where you can't do FISH for the c-MYC IgH translocation, you could do MYC immunohistochemistry as well. Some people say that it doesn't really match, and in fact, it doesn't match completely. But where it does, if you look at a whole range of high-grade B-cell lymphomas and see how concordant mixed staining is by immunohistochemistry with FISH, over the whole range of the different types of high-grade B-cell lymphomas, the concordance is not good. But in the subcategory of Burkitt's lymphomas, if you take a cohort of Burkitt lymphomas, the concordance between FISH translocation positivity for MYC and immunohistochemical positivity for overexpression of MYC is pretty much 100%. So if you've already thought from the Key 67 and the morphology, yes, I think this looks like Burkitt's, and you've got a positive MYC, I think you've nailed it, and you don't need to be doing FISH cytogenetics, which in many places is not available. That would be completely sufficient. Okay, I think I've spent quite a lot of time on that case. So are there any questions on that through the chat before I move on to the next case? If you see me moving around, I've got a slightly sore leg, and it gets a bit cramped if I sit in one position for too long. So that's why I keep on moving around. Any questions? No? Okay, great. We'll move on to the next one then. So this is a 67-year-old man, kind of like the other end of the spectrum, really, from that case. He's got a known history, I'll just say, of a lymphoproliferative disorder. Let's make it not too, don't give the game away too much. So a known history of a lymphoproliferative disorder. And he's got a drop in platelets and his hemoglobin. Now, his hemoglobin is 119, so relatively subtle drop, and his platelets are 98. So that's a significant drop. It should be 150. Neutrophils were normal. They were 2. So again, a very good, adequate core we've been given. Right. See why that. So this is the core of marrow. So a very long, good core. So the interesting thing to say about this is 67. So it is hypercellular. So if there's any kind of hypercellularity, you're going to kind of wonder what's causing that. So there must be something in this which is causing the marrow in general to be hypercellular. And it could be hypercellular either because there's an additional marked infiltrate, which is responsible for the increased cellularity, or there's an infiltrate which is causing a reactive, a relatively small infiltrate, which is causing a reactive kind of inflammatory response or reactive response in the rest of the bone marrow. And then the rest of it becomes hypercellular as a consequence. Or you can have lymphoproliferative disorders which have an autoimmune effect, and therefore you can get a kind of compensatory increase in different lineage elements in the marrow. So, but if you see a marrow like this in someone of this age, it is definitely a hypercellular, probably mildly to moderately rather than severely. Then you'd be worried what's going on in here. So again, we've got focal loss of paratrabecular fat spaces, some of the filling in of the fat spaces, like in this area here, you're kind of like losing them, they're not evenly distributed. Interestingly, he's 67, he has got some thin bones, so he may be developing a degree of osteoporosis. There are many parts of this country where 67 would not be considered biologically old, in fact, but he comes from Tameside, which is East Manchester, which has probably got the worst health in the United Kingdom. So he may well be an old 67 biologically, and already developing a degree of osteoporosis. You see these bone trabeculae are quite thin. So I think at this power, there is a suggestion that there's something going on in here. It does look a bit active. Let's look at it in a higher power. So it's interesting because we've definitely got, despite the fact that his platelets are low, we have got an increase in megakaryocytes. We've got one there, there, down through here, and so on. So we so maybe there's an autoimmune response, that he's got a degree of autoimmune thrombocytopenia, and that's why he's got increased megakaryocytes. The increased megakaryocytes generally look cytologically normal in terms of nuclear morphology. They're also lying generally singly. Well, they're all lying singly, so there's no clustering involved. He's also got reduced hemoglobin. There's an erythroid island here. There's more erythroid islands here and here. So erythropoiesis is also relatively well preserved, if not expanded. So it's possible, I think, that he's got an immune element to both the anemia and the thrombocytopenia. So let's just have a look at that. Yeah. Okay. So we think there's something going on. Look into it really high power to see if we can see any lymphoproliferative disorder. And I'm going through here. This is obviously a completely different scenario to the other one. And to be honest, I can't see anything. So I know that that is not very helpful. So in a case like this, you really need to use immunos. We could look at the Giemsa actually, because the Giemsa can sometimes differentiate the erythroid cells from lymphoid cells better. So the problem in this case is we have got increased erythropoiesis, and where you've got increased erythropoiesis, it can be very difficult to separate out on the H&E, unless you've got really thin H&E, erythroid cells from lymphoid cells. Let's have a look on the Giemsa, see if we can separate them out on the Giemsa. Because the Giemsa is an overlooked stain that many people do. I'm speaking from experience because myself I include in this. Many people do, and they don't pay enough attention to it. So I'm just trying to sing the praises of the Giemsa today and see what we can do with this one. And to be honest, I can't see anything standing out here except lots of eosinophils. There's lots of eosinophils. But otherwise, I can't see anything standing out at all. So in this case, I think immunos are required to make the diagnosis. I mean, I can say that because I know the diagnosis. It's also worth looking at the retic, actually. You might often get a very subtle infiltrate, and that will be highlighted by an increased reticulin. So the reticulin here is increased. Okay, so we have got, this is an increased retic, probably only grade 1. But again, that points to the fact that there may be some kind of infiltrate in here which is causing this to be increased. It doesn't tell you what it is, but again, if you saw this degree of retic, you wouldn't get this degree of retic in a physiologically reactive marrow. So it indicates there might be something else going on. So again, it kind of supports the fact that you should have a closer look. So can do a CD20 if that's available to you. And this is how subtle it is. But you can see there's actually quite a lot of disease in this area. Yeah. So we've got this intrasinusoidal pattern, which matches, in fact, the increased retic. So the increased retic was highlighting sinusoidal areas. Yeah, like here. So we've got an increased sinusoidal pattern of small, this is CD20, so small B cells. And this sinusoidal pattern is typical for marginal zone lymphoma, okay, and for splenic marginal zone lymphoma. So they were also positive for CD79A, and these were negative for CD3. Now, having seen that, it's worth going back to the H&E to belabor a point to see if we can actually spot them on the H&E. And despite the fact that you now know where they are, and I now know where they are, I still can't see them. Okay, I still can't make out those aggregates, those intrasinusoidal aggregates, and neither could I on the Giemsa. So in this case, it's pretty much you cannot make this diagnosis without doing an immuno. What you can say is that they've got constitutional, they've got other symptoms like thrombocytopenia and low hemoglobin, and they've got an increased retic, and they've got increased cellularity. So there must be something going on, but you have to do an immuno to find it out. Interestingly, marginal zone lymphoma is associated with autoimmune cytopenias, particularly hemolytic anemia and thrombocytopenia. Okay. So opposite end of the spectrum to the Burkitt lymphoma. I'm going through these very slowly. So tell me if this is too slow for you, or is it useful? Can we just have kind of a quick kind of people say if it's okay or not in the chat, then I'll know whether to speed up or not on other cases. But I've got tons of cases here to last me the next few weeks at this rate. Is this an okay speed or not for people? We've only done 2 cases in half an hour, but I guess that's going into them in a bit more detail. Anyone? Right, I think this next one I think I'll leave. That's not the most informative case. Participants list. Okay, so we go on to the next case. Okay, this is quite an unusual case. So there's a 71-year-old man, and he's got a previous history of Langerhans histiocytosis with prominent lymph node involvement, and now has spinal lesions on magnetic resonance. He's also got axillary lymphadenopathy. So previous history of Langerhans histiocytosis. And this is his marrow. So got a fair amount of blood clot at one end. And then moving across, obviously some fractured bone. And then for a 71-year-old, it appears to be hypercellular. But even at this power, it doesn't look quite right. It doesn't look like normal range of hematopoiesis in here. So we'll just look to see what we have got. So we've got some fibrosis here, which is worrying. So the only 2 instances in which you get fibrosis are either a myelofibrosis or a metastatic carcinoma. So looking at this, I think there is some hematopoiesis in this area here. We've got some residual erythropoiesis and some residual myelopoiesis. We've got some maturing neutrophils. Got some erythroid cells scattered around. But then at the far edge, in this area here, we've got these uniform atypical cells. Okay, so where you've got atypical blast-like cells in a marrow, you obviously always think of query lymphoma, query acute leukemia. But I think you can take a clue from the fact that there is also fibrous tissue in it here, increased reticulin. I'll just show you the reticulin stain. So this retic is markedly increased, grade 3 in the WHO classification, because it's got this purple stain to it. So these are reticulin. It's a reticulin stain counterstained with a trichrome stain, in this case elastic Van Giesen. And so that's obviously collagen there. And this is collagen here. So where you've got collagen, puts it into grade 3. So the fact that we've got marked fibrosis means that it can't really be a lymphoma that's causing the infiltrate or an acute leukemia. So we're left with either myelofibrosis or some type of carcinoma. So given that it doesn't look like myelofibrosis because they don't look like megakaryocytes, and the diagnosis has got to be a carcinoma. So these are the cells. So he's got a history of Langerhans histiocytosis. 67-year-old. Is this Langerhans histiocytosis? Doesn't really look like it. To cut a long story short, we did lots of immunos. It was positive for S100, which I think is positive in Langerhans, actually. So there's S100, that's strongly positive. And in fact, it shows that there is some residual hematopoiesis. There's occasional hematopoiesis areas like this one here. It's got a megakaryocyte and some erythroid cells. So we have got focal hematopoiesis still there, but a marked infiltrate. It wasn't positive for CD1A and it wasn't positive for Langerin. It was also positive for, we did tons of immunos in this case, if I can find them all. Oh, come on, find the actual area. It's control. Yeah. So this here is melan A. So it was weakly positive for melan A. Let me just have a look at the. My colleagues have said it's positive for melan A. To be honest, looks pretty weak to me. This is the melan A. I think I might have difficulty persuading you that this is positive. Yeah, so that area there. So it is weak, it is positive for melan A, which is specific for melanoma. It was also positive for HMB45, I think more strongly. So this is a case of metastatic melanoma, in fact, rather than Langerhans histiocytosis. There, the HMB45, which is another melanoma marker, is strongly positive. Okay. So unfortunately, not Langerhans histiocytosis anymore. Now progressed to melanoma, or developed melanoma separately. Okay, let's see. I think coming to the end of this pile, multiple myeloma. Yeah, let's do this one next. So this is an interesting case, this next one. This shows the need for clinico-pathological correlation. So this is 67-year-old man who so very interesting. So he had myelofibrosis in 2007. And for that, he had a peripheral blood stem cell transplant in 2008. So close on 20 years ago. He's now got thrombocytosis with a platelet account of 658. So upper limit of normal is 450. So not massively high, but pretty high. And he's also JAK2 positive. And the question is, has he relapsed his myelofibrosis? So I should also tell you that his hemoglobin is 175 and his white cells 12.4. So he's got a massively increased hemoglobin, mildly increased white cell count, and a moderate thrombocytosis. So I think this is a difficult case, in fact, to deal with. So there's the marrow. So he's 67. So he's definitely got focal hypercellularity, like in this area here. And the rest of it's mildly hypercellular, only mildly hypercellular. His bones don't look too bad, actually, for a 67-year-old, in contrast to the previous one where there was some osteopenia. This one's look normal, but the important thing is they don't look sclerotic. So obviously, if he's got myelofibrosis, you would be thinking about sclerosis. Some of them are a little thickened, like in this area here, but this is subcortical. There's a subcortical area of bone, and the bone is generally a bit thicker in the subcortical areas, but most of the trabeculae are normal for this age. In fact, normal for any age. It's important to recognize that when you if you transplant someone with myelofibrosis to start with, in the early, months or even up to a year post-transplant, there may be no residual myelofibrosis, but the bone changes will still remain, and some of the reticulin changes might still remain as they get remodeled out. But this is 20 years later, so they've gone back to normal. So it looks like there's not myelofibrosis. If we look at the retic, because that's also important. So the retic, so I'd say it's increased grade 1. So in the WHO, occasional fine fibers are grade 0. A network of fine fibers, which we've definitely got in places, got a network of fine fibers, would equate to grade 1. Additional coarse fibers would be grade 2, and additional collagen fibrosis would be grade, which is often associated with osteosclerosis, would be grade 3. So I think here what we've got is generally grade 1 at most. And again, that doesn't really go with myelofibrosis. So there is increased platelet count. He's got a history of myelofibrosis in the past, but nearly 20 years ago. Has he got myelofibrosis now? Well, I think his marrow is abnormal in that there's some hypercellularity. Obviously, his hemoglobin is very high and his platelets are high, so he's probably got a myeloproliferative disorder. If we look at the different immunos, so this is ecadherin. So this is for erythroid lineage. So that's probably a mildly increased amount of ecadherin, but ecadherin only stains the immature erythroid cells. You've also got to look at glycophorin A to see the mature erythroid cells. And when you look at that, there's tons. Okay, so he's definitely got increased erythropoiesis, markedly increased erythropoiesis. I think myelopoiesis, this is for myeloperoxidase. Yeah, that's also slightly increased as well. And the important thing is to look at the megakaryocytes. So we can look at the megakaryocytes on an H&E. Are there any clusters? Well, there are actually focal clusters here, and here, and here. And if we look at the CD61, we can see we've got focal clustering, like up here. So this is an interesting case because, so what do people think of this? If anyone was going to give an opinion, okay, fibrosis, sorry about that, Vinoth, I've missed that chat because I was busy on another screen. Yes, you can get fibrosis in mastocytosis, absolutely. It tends to be a bit looser. It's kind of more increased reticulin rather than full-blown fibrosis. But I take your point. You can get an increase in connective tissue in mastocytosis as well. Tends to be a bit more spread out. I've got a case which I'll probably show in a couple of weeks where there is in fact markedly increased mast cells and you do have increased reticulin, but it generally tends to be a bit looser than in metastatic carcinoma or in myelofibrosis. In this case here, any suggestions for what this will be? I'll have to make this the last case because I've got an MDT to go to in 10 minutes. Any? So looking at this superficially, you could say this has got features of maybe recurrent early myelofibrosis. There is a mild increase in reticulin, it's only grade 1. There is definitely an increase in megakaryocytes, and some of them are clustered, and some of them look atypical, so that would go with myelofibrosis. The bones, however, are normal. I think the main point in this one is the high hemoglobin. So it's 175. So that's way over normal. And in this case, it was considered that yes, there is a recurrent myeloproliferative neoplasm, but it was more likely to be favored PRV, polycythemia vera, versus myelofibrosis in this case. And I think that was based on the peripheral blood count. But that shows you've always got to pay attention to the peripheral blood count because you wouldn't get hemoglobin of 175 in myelofibrosis. Okay. I've gone through the cases probably in a bit more detail than previously, but hopefully that's good teaching. Are there any comments from anyone? Is that kind of what you wanted? Would you want something different? I know that I've also said that this coming academic year, I will also be doing some more lymph nodes, and that will probably start in about a month's time because next week is myeloma, and the following week is Dr. Patrick Shengarai doing soft tissues, and then we'll move on to lymphomas. Are there any comments from anyone in the chat before we finish? No? Okay. Well, as I say, I have got an MDT to go to now, so I apologize for having to leave a few minutes early this week. Look forward to seeing you all next week at the same time and for the remainder of the program.